Hi friends, hope everyone is fine. See, we already done small intestine, large intestine, the gastrointestinal tract of all people. Now what's left is the organs, the solid organs in the abdomen, the pancreas, and of course the liver, gallbladder, maybe spleen also, portal hypertension, all those things. I'll be doing the next 1 or 2 videos. So here we are with the pancreas. Pancreas, as you all know, it's pancreas. Pan means all. Creas comes from the word crevice. Crevice means flesh. So it's all flesh. But in appearance it is flesh, or it is like a muscle or something, but it does have it's a ductal system and all those things. So pancreas is formed early in life. It is formed from the primitive foregut. So pancreas actually develops as 2 buds from the foregut, one dorsal and one ventral, and I think the dorsal one. Dorsal means, this is ventrum, what you are facing. Dorsal is at the back, so the dorsal one actually rotates and. No, I think it's the other way around. The ventral one rotates because it has to come clockwise. It goes clockwise and fuses with the dorsal one to form the pancreas in the whole of the pancreas. It's formed from 2 buds, ventral, dorsal, and the ductal system also. But sometimes as a embryonic anomaly, these 2 ductal systems can remain separate, or even the duct itself, the pancreas itself can be fused together in 2 separate pancreas but fused together. It's called pancreas divisum. Pancreas divisum. They can have entirely different ductal system, 2 pancreas, dorsal and ventral, but it is of course situated at the C of C of the duodenum, at the center of the C. It's supposed to be a retroperitoneal structure. It's a retroperitoneal structure. Retroperitoneal in the sense that intraperitoneal, the peritoneum is just the covering of the intestines. Actually, what happens is the peritoneum comes from the back of the body and goes towards anteriorly, forwards. Then it covers all the intestines. It's called mesentery. That's the mesentery which fixes it to the abdominal wall. So in retroperitoneum, this pancreas also fixed to the abdominal posterior abdominal wall, but it's in the plane of all the big vessels. All the vessels, lymph nodes, lymphatics, the nerves are in the retroperitoneum. The intestines. But intestines can also be retroperitoneum. Like duodenum is retroperitoneum because duodenum is the C loop of duodenum contains the pancreas. So that's a retroperitoneum is just what can I say, an arbitrary division. Actually, there is no such division. But when you do surgery, if you want to keep the intestines out, you do a retroperitoneal dissection. So it is useful that way. Otherwise, it's all abdomen. So it's a posterior abdominal wall structure. It ranges along the upper abdomen like that, almost up to about 15 centimeters. This length, 15 centimeters, like that. Maybe there's more than 10 anyway. 15 centimeters. So it's a long structure. Most people who are not related to medicine may not feel that there is a structure over there unless they get a disease. But it's a very important structure in the sense that This is the one which produces most of the um, enzymes and fluid for digestion. Pancreatic fluid. It's called exocrine. It has got an exocrine function. Exocrine means actually crine comes from the word this in Latin it's called crimen. Crimen means a sieve. So exocrine means something which is sieved and comes out. Sieve, put it through a sieve. And there is another thing called endocrine. Endocrine means it is inside the gland itself. The gland produces this. I don't want to confuse you. Exocrine just means it's a secretion from the gland. From the pancreas, it's a ductal system is there. It has got cells also there. The cells will produce enzymes and fluid also. And then all this joined together, it comes out through the gland. Gland, it has got this duct is there. Gland has got a ductal system. It comes out through the pancreatic duct. That's called exocrine secretion. Endocrine means the cells are there, but the cells produce these enzymes or whatever. Generally, in pancreas, it produces 2-3 the things, like peptides, like insulin, glucagon, the opposite of insulin, and also what's another thing called somatostatin. 3 things. These are produced by different cells. They are called islet cells. So pancreas has got exocrine producing cells, which are majority, but they have got small islands of cells, islets, and it's called islets of Langerhans. I think Langerhans is a person. So Langerhans, it produces insulin. Majority produce insulin. They are called beta cells. They got alpha cells, beta cells, and delta cells also. Delta cells produce somatostatin, but most of the cells are beta cells. About 70 to 80% of beta cells produces insulin. About 10% produces the glucagon, the enzyme which increases glucose in the body, blood. Insulin opposite action, it reduces glucose, it metabolizes glucose, fat, and all those things. So exocrine function, endocrine function. So without much ado further ado, just go into the diseases of the pancreas. The pancreas, when you say disease, there are not many diseases. Any organ in the this one intestine, especially solid organs, they can have only few limited diseases. One is called the we can have inflammation. It's called itis. In this here it's called pancreatitis. Pancreatitis. Itis. It just means inflammation or infection. And the other thing is neoplasms. Neoplasm is cancers, and cancers, benign things and malignant things also. So here in pancreas, we'll go into the neoplasms first. Neoplasm means the malignant. Neoplasm means the tumors. We'll go into the tumors of the pancreas. And tumors, there are 2 types of tumors. Everywhere. One is benign. Doesn't bother you. It forms just this small or even large solid things. They are called benign, and the other one is called malignant. So here the malignant is in pancreas. Actually, we don't say benign. The division is not as benign. This one malignant. Here division is as solid and cystic. Cystic neoplasms or cystic tumors are mostly, I can't say mostly, about 50% are benign, and about 50% are malignant. Whereas the solid tumors are mostly malignant. So then you might ask, what are solid tumors? The solid tumors, one is called adenocarcinoma, ductal adenocarcinoma. It comes from duct, not from the cells. Cells are called acinus, the cell. So acinus cell carcinoma is there, but they are quite rare. Most are ductal, and the ductal is a fatal disease. It's a prognosis is very dire, very bad. Prognosis is not good, not good. Even to this day, our 21st century, pancreatic cancer means life expectancy is maybe 1 year. We will come to it a little bit later. And let's go to this one, cystic neoplasms. Cystic neoplasms, they got like everywhere. It's the cyst can contain a clear fluid. And they are called cystadenomas because some glandular material is also there. Cystadenomas. Then sometimes it contains mucus. It's called mucinous cystadenoma. The other one is called, which contains like water thing is called serous cystadenoma. Same thing everywhere, like ovary also, serous cyst and mucinous cyst. Here, but serous cysts are mostly benign, serous cystadenomas, whereas mucinous cystadenomas are about 50% is malignant, as I said before. So these are the cystic tumors of pancreas. Of course, other rare things are also there. I'm not going into that. Then coming to the solid tumors, first thing is pancreatic cancer. Pancreatic cancer means pancreatic ductal adenocarcinoma. Pancreatic cancer, pancreatic ductal adenocarcinoma. Acinal cell carcinoma, quite rare. Then you can get so there are the pancreatic cells, as well as there are islands of cells, I said, which produces endocrine material. That is called this one islet cell tumors. That can also there, quite rare. But when we say pancreatic cancer, it's ductal adenocarcinoma. And how does it present? Generally, it presents with certain percentage will have pain, about 60% will have severe pain, backache, things like that. But 40% need not have pain and all those things. Symptoms may not have symptoms. So they'll present with its secondary effects, like this one this one bile duct. There is something called bile secretion from the liver. The bile duct comes to the pancreas, then it joins up with the pancreatic duct, then they join together actually. In pancreatic divisum, in a pancreatic certain anomalies, it may not join together. Then it joins up together, and then it opens into the duodenum, the C loop that where the pancreas is situated, of the duodenum. That's how it is. So when the most of the pancreatic tumors lie in its head, the pancreas has a head, a body, and a tail. So the head is in the C loop of the duodenum here, just under the right hypo, just right part of the rib cage. Just under the right part of the rib cage. That is the head. The head is related to all the blood vessels there, like inferior vena cava, and so you can imagine if there is a tumor process or there is a cancer in the head, it can affect the blood vessels there, like the origin of this thing, what is it called, a portal vein. Hmm? Portal vein and this one, even inferior vena cava can be infiltrated. Then superior mesenteric artery is there. Superior mesenteric artery is artery which supplies the intestines. The stomach is supplied by another blood vessel called celiac vessels. Here, superior mesenteric supplies the intestine. So, main blood vessel to the intestine is from the superior mesenteric. So, it's related to the superior mesenteric also, the head. Then it produces all the secondary effects by stricture of the bile duct, because it goes and joins up with the pancreatic duct. So, it can produce jaundice. So, it can present with jaundice, can present with pain in quite a good number of cases. And pain is another thing. If somebody presents with pain in pancreatic cancer, prognosis becomes even worse, actually. Maybe they get 6 months. Those who present without pain, it's said that they can get about 12 to 18 months. This is what I see in the statistics in the book. That's why I'm telling you. It may not make much difference, actually. Then the third way it can present is wasting, because if the pancreatic glandular function can be affected. So it can present with not malabsorption, can sometimes present with diabetes. In especially old people, if somebody develops severe diabetes in old age, then you have to think that he probably has pancreatic cancer. So these are the ways it presents. Then you have to make a diagnosis. So most of the cancers are diagnosed by taking a biopsy, isn't it? Most cancer done by, for example, if you have tumor in this thing. In accessible areas, in all accessible areas, you get a biopsy. But is pancreas an accessible area? By no means. It's not an accessible area. It's in the retroperitoneum. And another thing is that if you put a needle into the pancreas, normally the blood vessel will seal up. But pancreas is very vascular structure, and if you put your biopsy needle, that will be the end of the patient. But of course, you can get an endoscopic biopsy if you do what's called an endoscopy through the pancreatic duct and get some brushings from there, or get the fluid from there. Then you can get a biopsy. But most of the diagnosis by CT. CT means computed tomography. The CT, nowadays, got smart CTs are there. They're called multi-slice CTs. By multi-slice CT, you can see the pancreas well. Because I'm saying CT first, because I always say abdomen ultrasound. Ultrasound also you can get a shadow, but what happens is that it's overlaid with your intestines. It depends upon the gas in your belly. If you have got a lot of gas in the intestine, you can't see the pancreas. So pancreatic shadows may not be that clear. But I'm sure the radiologists would say otherwise. They wouldn't want to hear it. But CT is the diagnosis of choice in making a diagnosis for pancreatic cancer. So you get a diagnosis, then what can you do? The only treatment, which is, cannot say effective, but the only treatment which is authorized is surgery for pancreatic cancer. But the pancreatic cancer surgery is a drastic surgery. What we do in a pancreatic surgery is we remove the pancreas and its related structures. Pancreas has got a lot of relation to the bile duct. So you have to cut off the bile duct from there. Then you have to remove the whole of the duodenum. And in the earliest, procedure called, this, what is that? There's a procedure for this thing, pancreatic duodenectomy. But the earlier pancreatic duodenectomy, we used to remove part of the stomach also. And nowadays they keep the pylorus. It's called pylorus preserving pancreatic duodenectomy. PPPD. That is a surgery which is usually done. So it's a drastic surgery. Mortality compared to aortic surgery mortality will be around 5% less than that. But here, mortality is around 7%, I think. It depends upon your age. If you are maybe between 60 and 70, the mortality may be around 7%. But if you are past 70, 75, mortality goes up to 9%. Past 80, you may have mortality well beyond 10%. So in geriatry now, people having old age, because pancreas, as you age, the incidence of pancreatic cancer also goes up. You have to think, you have to. This is the statistics. So, but and in that sense, I can say that more than 5% mortality in any surgery means a drastic surgery. More than 5% mortality in surgery means it's a very drastic, very serious surgery. You can have a lot of complications also. So in old people, if it's your father or mother, if they are past 70 years, I would advise you do a surgery for them. So what is left? You give a palliative. So best treatment for nowadays for pancreatic cancer could be palliation. See, most of them will, because 70% of tumors are located in the head of the pancreas. So if you so they will have bile duct obstruction. So if you remove, that's called obstructive jaundice. So if you remove or give palliation to the jaundice, it gives a lot of palliation. It gives a lot of pain relief and things like that to the patient. So there are three things for this thing, palliation of pancreatic cancer. The first one is, of course, redeeming the patient from pancreatic pain. Pain is very severe. It radiates to the back, and so for that there is something called we have got this triple ladder for pain relief. First one, you give the usual NSAIDs or paracetamol, and all that's the bottom of the ladder. Then the next one is mild opioids, and the third is severe opioids. But the best treatment for pain relief for pancreatic cancer could be either blocking or neurolysis of the pain nerves which supplies the pancreas. The pain nerves come from a plexus at the back of the pancreas. That area is called celiac plexus. So celiac plexus block or celiac plexus neurolysis with alcohol under endoscopic ultrasound is the treatment of choice. Endoscopic ultrasound, not CT guidance or anything. Endoscopic ultrasound can actually locate this one. Celiac means just refers to the celiac plexus block. Celiac plexus, that is a nerve which comes from the lower thorax, the pain nerves, the sympathetic nerves, and it forms a ganglion there, celiac ganglion. So you block that pain there. So that's the best treatment for pancreatic pain relief. The second is relief of jaundice. Relief of jaundice, you can have endoscopic, like put a tube, plastic tube or a metal tube, and or you can have radiologically put, can be transabdominal. But the surgery is also possible. You can connect the gallbladder, because gallbladder is connected to the bile duct, gallbladder to the intestine. It's called a cholecystogenital bypass. Connection. So the bile will drain into the intestine. That's also possible. But actually that gives more durable. That's supposed to give. The studies are there that better than endoscopic tube placement. This is better surgery, but I'm sure most people would prefer. At least in Kerala, they would want to prefer the thing endoscopic, because surgery means fear. Yeah, but it's supposed to be better. The surgery is supposed to be better, at least in this case. And of course, the pain relief can also be affected through the endoscope. Sometimes that there is a ductal blockage causing pain. You can do an ERCP, endoscopic retrograde pancreatic entry, endoscopic retrograde pancreas. That's called retrograde pancreatic. Put a tube into the pancreatic duct and take out stones or maybe which is blocking there. Stricture is there. Cut the stricture. Relieve the pancreatic secretion to flow out. Allow the pancreas. Then that can really give some relief. Same procedure can be done for chronic pancreatitis also. Chronic pancreatitis again. The main symptom is pain. So this is about pancreatic cancer and pancreatic tumors. And as far as pancreas is concerned, if you see a tumor, all are malignant unless proven otherwise. Even if it's a cystic tumor, you have to get do a surgery. And you have to do a surgery and remove the pancreas and send it for biopsy. Because even cystic tumors, 50% are malignant. Then the other thing is there are the pancreatitis. Pancreatitis, as one ages, the incidence goes up. Pancreatitis, of course, the pancreatitis, the main thing is pain, severe pain. But most of the pancreatitis can be mild. And regarding why it happens is most etiology. Etiology means the cause. The causation is about 50% is caused by the gallstones. Small gallstones going to the pancreas and sets up an inflammation there and produces. Now, how the pancreatitis comes about is, pancreas in Indian language is called Agneya Grandhi. It has a got of Agnayam. Agnayam is fire in it. The secretions in is fire. Actually, it cooks all the proteins and fat and all those things. So it can cook itself. That process is called pancreatitis. That disease is called pancreatitis. So actually, there are many causes, but ultimately the cause has to be this fire goes out of control. So the pancreatic enzymes, which are bound in by something, that gets released and it starts attacking itself. That's the pancreatitis. The main cause I said is gallstones. So if you have severe pancreatitis can be mild, moderate, severe. Moderate, severe, if you think it's caused by gallstones. Most of the gallstones come from the gallbladder. So remove the gallbladder is part of the treatment. Then another thing is it's all management, conservative management, keeping him the patient. Giving it is important to give them in severe pancreatitis enteral feeding. Enteral feeding means feeding to the patient cannot tolerate food. You have to give them enteral feeding. Enteral feeding, put a tube into the intestine and feed. Because if you give parenteral feeding, if you keep the intestine silent without giving it food, giving it succor, what happens is that the intestine will start reacting because it doesn't have food. It will start degenerating, and the bacteria will start attacking, going inwards. It leads to what is called systemic inflammatory response. Because the bacteria is absorbed through it's a translocation of bacteria. It's called translocation of bacteria from the intestine. It adds to the systemic inflammatory response as a result of pancreatic inflammation. So people actually generally die of this inflammation related to pancreas. By inflammation, because of this pancreatic inflammation, the inflammation first will see. I mean, I'm talking about severe pancreatitis, which is a norm in old people. So the first thing that it attacks is the lungs. The lungs will be damaged. So you have to watch. You may have to give respiratory support. Watch this oxygenation. And there are actually CT grading for the lung damage. Sometimes it can present as a respiratory distress syndrome and all that. So mortality takes place because of these things in acute pancreatitis. It can affect the kidneys because a lot of fluid can be lost in pancreatitis because of inflammation and things like that. And these are two things, lungs and kidneys. Then of course translocation through the intestine producing systemic inflammatory response affects all the organs in the body, including the heart. Heart can be affected. That's how mortality takes place in acute pancreatitis. And it's sad to say, in old people, many may not see the day because of severe pancreatitis. Then pancreatitis lasts for about 1 or 2 weeks, but that's not the end of the story. The pancreas can form what's called it can get necrosed. It dies off because of pancreatitis. It forms what a pancreatic necrosum. And there are again CT scores are there to find if there is a necrosis. So you should get a CT after about 1 week for pancreatitis. It's called Balthazar scoring. I'm not going to the details of it, but scoring is there, and you can find the necrosed pancreas, because pancreas, as I told you, is a very vascular organ, but once it necroses, it may not show vascularity. So you can say that this thing, vascularity is not there. Necrosis has taken place. Necrosis can get infected and lead to mortality. So in that case, you don't have to remove the necrosum if it's not infected. But if there's a lot of infection, you have to remove the infection with a necrosectomy also. So this is a acute pancreatitis. The last topic I'm talking about, chronic pancreatitis. Chronic pancreatitis actually is not a disease of old age, because people are having chronic pancreatitis die of maybe 10 years before the usual mortality, that bracket, 70s or 80 years. So it's not a disease of geriatry, but just passing, I will say that chronic pancreatitis, the main thing is pancreatic pain, because the chronic pancreatitis produces distortion of the duct system of the pancreas. So it can have stricture, and it can have stones in the pancreatic duct. Stones in the pancreas. Actually, pancreatitis diagnosed by chronic pancreatitis mostly diagnosed by an X-ray. You can take an X-ray, not CT. X-ray and see a band of stones at the back of the abdomen. That's our diagnosis. Of course, better diagnosis CT, but X-ray even can suggest that there is some stone there. And pancreas can have exocrine failure, endocrine failure. Exocrine failure means malabsorption. Endocrine failure means the hallmark is diabetes. So most of them will have diabetes, pancreatic. So the relief is generally by relieving the ductal obstruction or removing the stones. The gold standard for removing the stones is not surgery nowadays, Maybe it is supposed to be the same thing which we used to break the stones in the kidneys and all that, ureter, kidney, this one, this one shockwave lithotripsy, ESWL, endoscopic shock, no, what is it? Endoscopic, yeah, shockwave lithotripsy. You put this one pressure shock, this one onto that, and it can break the stones, and probably it can then be taken out. If it's not coming out through the duct, it can be taken out endoscopically. Of course, endoscopic, stricturectomy, all that is part of the armamentarium. The best is probably a surgery. Again, it's called a Puster's procedure. Puster's procedure is a pancreas is cut longitudinally, then it is the duct is open, the stones are removed, it is connected to the jejunum. There are variations of surgery. There is one procedure called face procedure, where you remove the head of the pancreas also, because head of the pancreas is the place where it affects the